you see the full screen mode, or is it still a
Yes.
slide?
Yes, we can see the full screen. Yes.
Okay, fantastic. Okay, so I have a case to share with you today, and I've kind of labeled the title here as "Is POCUS only for the very sick in the ITU?" So I think there is still an impression that the big scanning machine gets wheeled to that end of the neonatal unit where you have really unwell babies, or a colleague thinks there is a need and makes a referral, and you go and scan, and there's the unwell scenario. But here's something I wanted to share. I am sharing today with you, where there was apparently no uh, big referrals or calls for help or anything. It was the nicest end of your unit, where towards the end of the ward round, you're almost half asleep because you're standing in that big room with feeders and growers. So all the nice babies with tubes in, eating for Scotland, and no respiratory support mostly. So that's where. So I'll take you on the journey with me. So I walked into that end, and me and the rest of the mates on the ward round, we came across this lovely twin boy. So he and his sister, very cute, in the same cot, no respiratory support, tubes in, 7 days old, or day 8. So this boy is a twin one, and on that, the two were born 34 plus 3 weeks, and this boy was born with weight of 2392 grams. And a bit of story here in the background is that there was no space in our unit, so they went to Edinburgh intra-utero, where an emergency section, not in labor, was done to get these two out in good condition, 99 APGARs for both. The sister was always okay. This boy needed a little bit of IPPV, then he needed some CPAP, and initially some documentation of some high oxygen requirement. But very quickly, within hours, he was in air on CPAP, got his feeds done, the bloods, infection markers, everything was okay. So in about 1.5 day time, so about 36 hours, he got rid of his CPAP and was in air. So a couple of days later, when we had bed these two siblings, they traveled back to us, both with no respiratory support and tube feeding, and recovering the weight they had lost. So so with us on day 2, or not day 2 of age, but in our unit, after 1.5 day later, the boy was noted to have lowish saturations. So with a little bit of hesitation, in the absence of any increased work of breathing, in the absence of any incidents, nothing funny happened. So they were trying, the team in my unit, they placed him back on low flow, which was off and on, but they were giving it. So when that day, when I saw him, he did have mild work of breathing ongoing, but it was mild. He was still showing hunger cues. There was nothing majorly had happened. The gas was pretty acceptable. The CO2 was slightly high, but then the mind was that, okay, a good weight in gestation, but still we are premature and low birth weight here. And the baby was on a few molecules of oxygen per minute, and no issues with the feed. So I thought this is a step back. There are some risk factors here, although the antenatal scans, everything, there was nothing to suggest anything. So and he didn't look septic. So I thought I'm going to move him to the high dependency side, see it how the guy stays there. No plans on disturbing his feeds or escalating his respiratory support. But yes, cannula in, send some bloods, get another gas, sort of thing. And I didn't think, and then I couldn't see any reason why I would feel the sky is about to fall. And yes, we did second the antibiotics, but that's part of the partial sepsis screen, because I wanted to take this this issue as per protocol, because this was going on for a couple of days. However, I went ahead with the lung scan because that's part of my ward round, is part of my auscultation. So I just wanted to know this step back happened. What is to have some evidence on the scanner, or maybe something more. So there was nothing much on my head anticipating. So I placed the probe on, and that was so you're seeing. So this is the left side, the left anterior zone with the probe held vertically. In area 1, which is the apical side. So let's just revise a little bit. It's always good to go through the basics. I keep learning by revising. So if you follow the pointer, so you're seeing the skin and the subcutaneous stuff, rib impressions here, intercostal muscles. Then you're seeing this I would say continuous pleural line, which may be slightly thickened, possibly some subpleural echogenesis when the baby expires. And underneath this is this, I saw this very unexpected number of frequency of B lines. They're merging into each other. And when the baby inspires, there is some impression of A line-ish, some alveolar recruitment curtained over by the B lines. Sliding the probe down, again held vertical, left anterior. A similar finding. You could say that the pleural line is a little bit thickened, and then the B lines were far more prominent than I expected. And on the lateral side here, again, this is the similar finding. So I was thinking the entire left lung is giving me a score of 2 in every windows and every zone here. So am I having the pretty uniform appearance on the left lung? However, it wasn't just the left lung. When I moved on to the right side, so here where the pointer is, right anterior, with the probe held vertical in area 1, very similar, very homogeneous finding here again. Sliding the probe down, slightly more A-line-ish appearance, but still it's a B profile predominant appearance here. And the lateral side again was a picture. So I didn't see any pneumonic patches here. I didn't see any big collapse here. I didn't see any fusions or any air leaks. But this was still totally beyond my expectation. I wasn't expecting this is quite a whiteout. Although I don't try to depend on the number, but it's a good objective thing. And if you score this will be like 11 or maybe even 12 for these. So I wasn't expecting an 11/12-ish score on the lines. So what I did is what my current and established practice is, not my units, my practice, that I use the probe with dexterity, and I went ahead with some targeted views of the heart. And this because I never see lungs and hearts two separate things when it comes to scanning. I know there's a bit of a debate that why targeted echo images, why not the whole. That's a talk. But the thing is, right now nobody had asked me if it suspected a cardiac problem here, and I was doing a pathophysiology scan, not. So some targeted views of my choice. So here is the 4-chamber view. So naked eye, eyeballing, I could see a big right heart dilated, right atrium dilated, right ventricle, a squished left hand. Could this be my angled probe? But putting the Doppler in, there is a tricuspid regurg, which is that looks significant. So so it was okay to buy this dilatation on the right side as a reliable image. It's not my skewed hand or something. And there was about 3.5 meters per second of regurg I measured. So I quickly moved on to see what the PFO was doing. So remember, this baby is like 8 days old. So here is an aneurysmal flap around the PFO area, and you can see here where the pointer is, it's all blue. So so far I have a dilated right heart impinging on the left, 2 tricuspid regurg, 3 the PFO is almost completely right to left. So I think I just brought these images because I know some of us like to see this view in an inverted fashion. The findings are the same. Then I quickly had a look at the tricuspid valve from the long axis position. So you can see it's a big right ventricle here with a bit dilated right atrium, and the regurg is visible here with a decent almost a full thickness signal. So then I needed that I knew we are in trouble of some sort. So we moved the baby not to HTU to ITU, high flow, cannula bloods, get an X-ray done, start bank and gent, get another gas, and to find an answer, I needed like 15-20 minutes of sequential segmental analysis on the echo with hemodynamics. So this is the X-ray, which is pretty much in keeping with the lung scan. There is a very homogeneous appearance of lungs on both sides, ground glass. The heart shadow, the heart silhouette doesn't look bad at all. And that's what the consultant radiologist says. Diffuse ground glass change throughout both lungs in keeping with the history of prematurity and representing surfactant deficiency. No pneumothorax, normal heart size. So at that point, you know there is something wrong with the heart. You have this triad of big right heart with tricuspid regurg and right to left flow. But the X-ray, it didn't help me much. I mean, it's showing something which I knew would be there, and it doesn't give you any clue on any cardiac problem here. And I would say somebody else who had not scanned the lung and the heart after reading this report would have, start considering surfactant or something. This is pretty impressive. It is pulmonary edema, but it does matter when it gets reported as surfactant deficiency for a reason. So I'm not saying anything here is misleading. All I'm saying is the X-ray doesn't help you tell any further. So then I got my hands on with 15-20 minutes given to me on the chest for a proper echo, sequential segmental analysis of some as far as hemodynamics as far as possible. So I started with the usual routine, and you're doing the echo with me now. So here, where the pointer is, the spine, aorta, IVC somewhere here, a bit of gut here, and the liver all over. And I did notice some juicy looking big hepatic veins here. Then the situs is normal. And here again, you can notice the tricuspid regurg and the blue a right to left PFO here. But so this is the view for the situs. And these are the two views. I do them routinely just to see the LVOT and RVOT from the subcostal. So here you can see a lovely aorta coming out all the way. You can see the SVC going in, and here, if you angle the probe further up, you can see the main pulmonary artery coming out, and decent looking here. And I'm sure you have now started to observe what's beyond the left atrium. There is there is something there. Then, as per our routine of doing the echo, I went on to the IVC. So you can see the IVC here nicely going into the right atrium. This is probably the eustachian valve and those fat hepatic veins. And here is, so that's a Doppler where you can also see it's kind of bicable. You've seen the SVC coming in as well. And those hepatic veins, which are a little bit more attractive than usual. And this one down here is just a swing towards the left to see the aorta. So you can see the aorta in all its length, curving all the way up to disappearing into the out of the plane, and then you can see pulmonary there. So that's the usual sequential segmental analysis I'm doing. So then up the chest, the 4-chamber views. So again, I'm pretty sure my hand wasn't skewed. It's a good, reliable image, and it's a very dominant right side of the heart with the septum bending into the left. And we've talked about the tricuspid regurg and the right to left. And you can also see the impacted flow from the 2 atria into the ventricles there. Then I moved the probe a little bit towards the shoulder to get the 5th chamber in. So here it was almost looking like a hypoplastic left side. This is so I used this to measure the VTI and stuff. The flows were okay. It wasn't a low flow state yet. And again, you can see here now. I'm sure you're getting very suspicious of things behind the left atrium. So there is this usual appearance of the pulmonary vein, but it doesn't seem to be going in. There's a tissue here and it seems to be going somewhere else. And however, here it's not very helpful saying where it's heading to. So I moved on to the long axis. As expected, dilated right ventricle, septum impinging on the left ventricular, on the left ventricle. And I'm seeing some left atrium here with loads under it. That's the aorta going out, and in this view there's Doppler and I can see pulmonary veins, but I can't see them actually going in there. So some impression. I did some usual mode stuff, and I realized that on trying a little bit more, the long axis wasn't as nice as it was visible earlier. Yeah. So then let's move to the short axis. So from the long axis, I had a look at the tricuspid valve again, and the regurg and the findings we've seen before. That's the short axis here. So we got the aortic valve with the right heart wrapped around it, and it is a laminar flow in the pulmonary artery, main pulmonary artery. I couldn't see any duct here, and I was keen to see the duct, so I moved here a little bit lower chest just to see this area where the aorta, this area here. Couldn't see any ducts here. And then I moved up the chest for a ductal view. Oh, sorry, not on the slides. Have I seen this? Okay, so yeah, so this is short axis. This is for just to demonstrate a tricuspid normal looking aortic valve, and the coronaries. One is going here, the other one is here. And yeah, this was for this purpose. And again here, I could see some problematic area under a squished left atrium. So going up the chest, it's a nice laminar flow in the main pulmonary artery. No evidence of duct here. It's gone now. Nice diameter of the 2 pulmonary arteries, and that was the moment when you are going to tilt the probe back towards the back of the heart and see what's going on. So let's take this one first. So that's the aortic valve in the middle. That's the pulmonary valve, and obviously the pulmonary artery has gone out of plane to allow us to see the left atrium here, which is, if you say take the whole area here as something, there's something dividing it or something separating it. And there is this pulmonary vein which you can clearly see draining here, not there. And if you see this image here, you see a pulmonary vein avoiding the left atrium, and there's another one. So that blue color in both sort of confirms that the flow is towards this confluence. However, I hope you can at least try imagining yourself in my shoes. It is a nice sunny day, nothing happening in your unit. You walk into, you're finishing the ward round, and suddenly you don't feel like saying, "Oh gosh, this is a TAPBD, guys. Scott Star, do something," and all the shebang. So I was still thinking here that could it be that in this area the pulmonary branches, the descending aorta, am I confusing something here? I mean, it was a little bit too much, too sudden to suddenly turn around to parents and say, you know, your baby who never had anything has a TAPVD. So I really wanted more clarity on this. So I placed some. So that's the range gate here on one of those. You can see some arterial pulse overshadowing, but still, I think there is no doubt that this is a very venous flow here. Then the range gate is on the other one, and they're both veins. And if you remove color, you can very clearly see this separating tissue, the confluence of the veins separate from the left atrium. And then I did get this image where the whale tail plus the pulmonary bifurcation. So you cannot challenge me on this one, that I was clearly seeing. I was confusing any pulmonary bifurcations or descending aorta with something behind or beyond the right atrium. So this view, I thought, okay, I have anomalous pulmonary venous connections. So is it supracardiac? I'm going to chase this abnormal vein. Is it the vertical vein joining the SVC system, or is it going down in the tummy? So it was time to chase it because I knew this. So the SVC first. Okay, hang on, don't stop. So you're seeing the SVC. Okay, I don't know why it's not running. Okay, so that's the SVC. This is the inferior superior vena cava, and this is the right atrium, and this is the veno-caval, veno-atrial, cavo-atrial junction here, and this smallish area probably is the left atrium under the, and there is this thing, orange. And anybody wishes to comment on this one? I'm trying to run it.
Vertical vein.
Okay. Well, vertical vein, did you say? Okay. Yep. I think. Anybody else? So I see this this one very often, and I chase it in all my echoes. As you know, Giza, myself, and some colleagues, we're although a little bit late, but we're trying to get some guidelines and stuff for the lines. So we look at the SVC a lot. So I look at the SVC a lot. That's one of the ezigus. That's not the vertical vein I was very suspicious of. So I see this very often. I have lots of echoes with this one visible here. So then, as a routine part of the echo, I had a look at the arch of aorta before going under the diaphragm. So here is it's a nice one. Three branches. You can see all the way down, and with Doppler, and you can see the flow is pretty laminar. So there wasn't much to really worry about this one, and I couldn't see any ducts under it. This is the right pulmonary branch, and usually if there is the worry for duct is that under the circumstances it would be blue, and there are, so it's not as easy to see as the red one. But I was okay with the arch of aorta, the branches, and nothing here. So then I went down again on some interesting views and tried to see if there is. So first of all, this is far too much for simple, straightforward dilated hepatic veins. So which is which. I thought these were dilated veins, hepatic veins, quite spectacular. But I needed something, going into the heart, and I could see that it or coming out of the heart or something. So this orange looked different. So I went on chasing further. You see this one. This is so aorta is somewhere here. IVC somewhere here. Now this one is very unusual, spectacular, and it does go into the heart very clearly. And when I place some Doppler in it, you can see that it is a vein. It really is a vein. I'm not confusing it with something else, and it has a different direction, and it is going into the right atrium or coming out of the right atrium. Here again, you can. I was able to see the whole length of it. So obviously, it's a 2D thing. It was the CT scan that delineates the exact path, but this was, I think, quite revealing. It's a long one. It's an abnormal one, and it's heading straight into the chamber, into up the diaphragm, and then yeah. So there were I changed the proposition just to keep tracing this vessel, and you can see it's very convincing now here in both these views. And yeah, it's the same one. Okay, yeah. So this was actually the last slide on the echo that So these were the two images which I very quickly WhatsApped to our cardiology on-call people, and they didn't have any objections, and it was a convincing anomalous pulmonary venous connection. And then and the baby by that time was still okay. It wasn't as bad as what I found here, but I did an elective intubation with sucks and some morphine, just to make sure he doesn't decompensate himself, and to get him teed up for transport. So he was within hours. He was in Glasgow, where our level 4 cardiology unit is. And the same, within a few hours, they did a CT scan, confirmed the diagnosis. He had his surgery correction done because he was relatively stable. So it was a subdiaphragmatic intracardiac total anomalous pulmonary venous connection. And he's a little fighter. He's although still in PICU, but he's doing all right. And this is just there's an X-ray which I did after intubation. So he was getting worse by the minute, and it was more like my feeling that day was that it was a ticking bomb sitting in an area where nobody had even imagined that this sort of rare, severe thing is sitting. And because this is intradiaphragmatic, which is it's not a Prostin situation. It's not a duct dependent thing where you would give Prostin and everything will go fine. If this vein had obstructed earlier or at any time, your Prostin, your inotropes, nothing would have. It could have been a disaster. And the baby was in the feeding and growing end. People would not even have known why we lost the baby until postmortem or something. So that was, and it all began from and our current existing practice. We'll talk about this, but yeah, it was an interesting day. So I'm sorry I couldn't bring CT scan images, but it was confirmed to be what I just showed to you. So if we're not reading all of this, I just wish to say that some of this images was able to show that the separation between the pulmonary venous system and the left atrium. So embryologically, the heart and the lungs, they develop separately, and there is this primitive pulmonary vein that comes as an outpouching from the left atrium, which joins this system here, and then this confluence gets either gets incorporated or kind of become part of it. And in anomalous pulmonary connection, so that confluence doesn't become part of the left atrium, and it just drains through a vertical vein or an abnormal vein into the superior vena cava side for if it's supracardiac. It goes under the diaphragm. If it's intracardiac, it goes into the drains into the coronary sinus or somewhere in the right atrium in the cardiac variety. And there's a fourth one with a mix stuff. So so ours was this one where I saw that big orange thingy. So when I show yeah, so this vein then goes hits the ductus venosus, and that's the pathway it uses. And this was for ours. So it's yeah, that's the kind of incidence. But what I found interesting is that the male to female ratio is 4:1. So I had this boy and the girl. The boy had it, and obviously I was very quick to do the scan on the girl as well. But she's the best teaching material echo, perfectly normal. And no, although there's no genetic pattern of inheritance, and there's nothing much in that I know is associated with this. And this boy didn't have any other malformations, but there are certain malformations that are associated with, I think, isomerism, splenic isomerism, and some. There was another case that I've seen with imperforate canis, imperforate anus. I have a presentation on that also, but yeah, no, there's nothing syndromic on the face. So before I invite your comments and questions, I just wish to comment on or just wish to ask you that is the existing practice of not using point of care scan as part of your ward round in today's world, is it safe anymore? I think it's time it should be part of. It has to be more than just the ITU toy, and all sorts of funny things. They don't really help. The snowman appearances for supracardiac, I understand, but still, it's how helpful the existing thing is. And this guy was on oxygen, went back on oxygen 2.5 days before I saw him. So with those mildish symptoms, there was no reason to think there's a TAPVD, unless of course you're scanning for just to see what the pathophysiology of even a mild onset of something that gave away a direction. And my second comment here is that, which you have heard before, but I've been practicing this for a long time. When you go in, I think there's a wealth of information I would miss if I just scan the lung alone and walk away, or just scan the heart and walk away. They're not separate from each other, and when you're looking for a reason for anything, for say a high oxygen requirement, you should look at both. Where's the reason? So scanning alone is, at least as far as I'm concerned, scanning one system as a separate system is. I've abandoned that practice. I always use the probe with dexterity and see everything there as far as possible. It doesn't take longer. And with practice, it's nice and quick, and you get a wealth of information. And yes, that's it. So I will bring it back to this favorite slide of mine, and then I'm going to ask you to ask. Yeah. So please, your comments, questions.
Thanks, Ahmed. That's really interesting case. I think Sujis has a question for you.
Ahmed, thank you so much. A very interesting case. One of the things is, I think in your initial images, the two red flags that I found was a pure red right to left flow across the PFO, and the fact that you have dilated hepatic veins. And I always, when I teach my trainees, I say a pure right to left across the PFO is TAPVD until proven otherwise. But I think this is a very good pickup. And if you look at the descending vein that you can see on the left-hand side, I mean, you can see some aliasing right in the middle. I mean, this is probably an unobstructed TAPVD, isn't it? So if there's high chance of getting obstructed and then the baby collapsing, but you can see that aliasing, and probably if you put the pulse wave Doppler there, you'll see there'd probably be exaggeration of your velocities. But I think it's a good pickup.
Yeah, it was unobstructed at that point. Yeah.
But what is interesting is you picked this up after doing the lung ultrasound, which is interesting, I have to say. Well
absolutely, that's where that get debated a lot in our place here. I think that was the turnaround really.
Ahmed, can I ask you? You said you do lung ultrasound as part of your ward rounds. Is that so? What cases do you select to do this on, or do you sort of do it on babies with tachypnic? And what is your indication for doing a lung ultrasound?
So I keep keep Stella around close and ready because I find that's the biggest problem. That one of my NNPs has named the scanning machine Stella. So turning it on, and that takes time and stuff. So I keep it ready, and then it's not for every baby essentially, because you don't examine every baby, you don't auscultate every baby. But for anybody, if I'm not aware of why the situation is like this, and for example, a new admission, or or somebody who has fallen back to, even if it's a low flow, and all those. So these are the ones where you would probably not do a lung scan, but these plus everybody else who's needing a higher degree of oxygen. If the FiO2 is high, it's not surfactant, it's just delayed transition, I would scan. I would not, for me, the delayed transition is not a clinical diagnosis, there has to be evidence. So what happens in the end is that they're about, I don't know the percentage, but it'll be like 1/3 of my patients would get a scan in every ward round. Yeah, so there's a I use the scanner almost like a stethoscope.
Thank you so much, Ahmed. Well done.
Yeah, I agree, Ahmed. I think this practice probably should be more kind of widely used. For me personally, if I need to request a chest X-ray for any baby, I will just scan before that. And obviously, if you find a lung scan out of context or a clinical picture, that will just make you wonder what's going on. Then just get on with the cardiac scan. But I think you raised a very important point at the start of your presentation about the POCUS versus complete echo. And this is a big question. I'm not sure what's the best answer for it, but probably because you, for example, you picked up the right kind of views you want to scan, because you went from the 4-chamber to the PFO. Somebody else might not look at the PFO in the point of care, like targeted echo. So I wonder, is there a merit if you decide the minute this cross your mind, you want to do an echo, probably should do a proper echo then? Well, I don't know, it's a question up there.
So you want everybody to answer, because there's some great people here. I mean, for me, all I'm saying is that I get this feeling that the information is lacking evidence, no matter how small. There's so many things, including delayed transition, where you just say it. People just say it. Where's the evidence? You're assuming it, right? So I just can't swallow the assumption. So I like to have a look at what the pathophysiology is. Even if I'm saying if it's fine, how do I know it's fine now?
Absolutely. Because I will give you an example. I have already been through one case where it was like a late preterm, very tachypnic on CPAP with lung ultrasound indicating probably interstitial syndrome or lung, maybe RDS. However, the oxygen requirement was way above that, like 60, 70%. When I thought that might be pulmonary hypertension as well. And I was very tempted just to put the probe on the 4-chamber view to look at TR jet, and that's it. And that's the danger of it, because when I did the full scan, it was supracardiac TPVD. I don't know. I'm worried that people might miss critical congenital heart disease.
Okay, so fine. So you have started this debate now. See, the thing is, let's take us out of the equation for a second. So there is a colleague who's a seasoned neonatologist, and he has nothing to do with point of care scan, but he's a fantastic neonatologist. Now, this gentleman, this colleague, reviews a baby, and there's a certain management, and the need for any cardiac assessment does not cross his mind. The thought that there's a cardiac anomaly doesn't come to his mind at all. He's not made a cardiac referral in the first place. He doesn't think there's a cardiac problem here. So in that case, why should I go and start doing a definitive echo on the baby? I should look at the heart to find an answer that this baby has an oxygen requirement of, say, 30%. And people are assuming that he's a little bit premature and this is a bit of a partial surfactant deficiency and you're not doing surfactant, but that's the reason. That's not good enough for me. So there's no suspicion of a cardiac problem, okay? I'm not expecting a structural problem here, but prematures, for example, can have delayed transition as well. So I would look at the heart very quickly and choose some targeted views to justify my theory on it. So you cannot object to me not doing a sequential segmental analysis, because the colleague cannot object to not doing a full scan because he never asked me to do a full scan. So whatever information I'm giving you about the heart is an addition. It's a bonus. And in the process, yes, I found this one. I found that massive pulmonary embolus, pulmonary thrombus. There's a massive list of incidental life savings that happen, but those are not the guiding examples. The thing that guides me and the inspiration is that you get a baby, this high oxygen requirement. Why did you just put it on lungs and certain assumption? And why should I do a full echo with E primes and A primes, because when the colleague hasn't suspected a structural problem there? So I hope I'm trying to make my point across. I don't know. I'm talking. I need more organized speech on this.
Okay, so just.
No, I see. I just wanted to say that, Mahmood Fi, so for me, a point of care ultrasound does not equate to echocardiography. So point of care ultrasound, you have one specific question in mind. For example, in a baby with a long line sudden deterioration, are you looking for effusion? What is the cardiac contractility? So that it gives you that particular answer. But I think here, the key is, if you have a colleague who's learning to do is, once they do that 4-chamber view, they need to appreciate that there's something wrong with this and then call for more help, if that is somebody who's training. But I think when it comes to structural echocardiography, I think doing focused views, you're likely to miss things. You need to go ahead and do the whole sequential segmental analysis. And I think that's what's happened here. But I agree, point of care ultrasound has its roles, but I think practitioners need to be fully aware of its limitations, and they need to practice within their limitations and know when to call for help. And I think that is key, and that sort of point should be stressed when training the younger generation.
Yeah, thanks, Sujit.
Yeah, Suji, that's fantastic. Yeah, so so for point of care ultrasound, I would say, like you said, there should be a question in your mind. You're answering a question, and to answer that question, you're going to choose what you want to see. And when you're suspecting something, there is no argument that it should be a full, decent, definitive scan or call for help.
Yeah, Abhijit?
Yeah, hi, Mahmood. Yeah, just echoing, Sujit's thought here. So I'll share a small experience recently in Paisley. So one of the baby, late preterm, lying in the corner of the room. I have been asked to do a lung ultrasound because baby was a bit on the tachypnic side, and we couldn't find any reason for that. I didn't know the baby at all. I was just, randomly showed up that day in the unit. So I did a lung ultrasound, and I couldn't, point my finger and say that, this is what is going in lung and which is causing this baby to be tachypnic, or the need of oxygen. The baby wasn't low for not a massive amount of oxygen, but that was new for that baby. So the question is, what do we do after that? There was a, audible murmur. So I decided to do an echo on that baby because I couldn't find anything in the lung. And to my surprise, that baby was having the tetralogy of fallow variant with a very narrowed caliber of the main pulmonary artery. So, but then, I don't do a structural, or I'm not qualified for a structural, scan or this echo. So next step is definitely, sending this baby out to the QA and then asked a formal echo by the cardiologist. Yeah, so we have to be, aware of our limitations there. But then point of care ultrasound is the beginning here, if you see what I mean. So I went and did the lung ultrasound, but I couldn't find any reason, and that sort of pushed me to do, okay, let me have a look at the heart and find if I can find something. And that baby got a TOF variant.
Yeah, that's very interesting one. Maybe you can present that for us next time.
Yes, Mahmood, I'll surely do. I was just, thinking of presenting that one. Yeah.
Yeah, that's the worst presentation. Thank you. Zoltan, please.
Hi, absolutely superb case. Honestly, guys, I mean, it's just such a joy to join this forum. Can I ask something in terms of when you did the lung ultrasound? It was very tricky, interesting that this baby, instead of venous congestion on the X-rays, and it looked like a full-blown RDS, like alveolar collapse. So I'm not saying that there was a clear distinction on the X-ray. The X-ray looked like RDS. So does the ultrasound, the lung ultrasound, looks absolutely like an RDS? This is how full-blown RDS looks like. And is there a way on lung ultrasound to differentiate venous congestion from alveolar collapse? Or how does look this one and how does the other one look?
So the lung ultrasound is very, very, very dependent on clinical correlation. So if this was like 8 hours or 6 hours person, I would probably not even, I wouldn't have doubted any. So that age, surfactant deficiency on top. But at 8 days, yes, the findings are the same. You're right. I think there was no collapse there, but it was like this was alveolar edema stage and scoring 2. And it was, if you do too many scans, yes, it didn't look like a surfactant deficiency in a 6-hour-old, but it's very similar. It's very similar. And the difference was the fact that it was an 8-day-old baby, and I wasn't expecting, and the fact that he wasn't in much of respiratory distress, and not much of the gas was almost normal. So surfactant deficiency did not fit. I had no problem in being different from the radiology consultant, who unfortunately they're non-clinical. They don't see the patient. So I could see that I have the advantage of seeing the patient, and based on that, this pattern, which is very similar to surfactant deficiency, homogeneous everywhere, scoring appropriate for surfactant replacement, was not surfactant deficiency.
Mm.
Yeah, so the picture was like of a wet lung, if you like
Yes.
pulmonary edema. And finding on lung ultrasound will have just homogeneous B lines everywhere. Whereas in RDS, just maybe there is a subtle difference between pulmonary edema and the RDS. Is the RDS, you will find the pleural line more thickened, more fragmented, with small subpleural consolidation. But again, as you get more edema in the lungs, that might mimic the same picture. But as Ahmad said, the timing is very crucial. Like the first 1 or 2 days, probably this is RDS, versus later on could be like pulmonary edema from maybe a large duct or heart failure or whatever.
Yeah. Okay. Many thanks. Yeah, and I fully agree. I think late transition, I'm not saying it doesn't exist, but I mean, it must warrant full investigations. And I always go and chase these babies on the unit to, do an echo, the proper so yeah, I think it must be looking at, rather than just say, okay, late transition, let's give another few days. And absolutely superb catch. And yeah, for the train is that I think that's why the segmental nature and the sequential segmental nature of the scan is absolutely crucial. So when you are doing the subcostal longitudinal view, at the time when you start sweeping between the IVC and the aorta, you probably would have caught that vein, isn't it? So that was so big and so abnormal and so upward. Flowing, which just doesn't fit with normal anatomy, isn't it? So actually at that point of the scan, one might have quoted that there is something very abnormal going on there at venous level, isn't it? So that's why it is always important to just do the scan properly. But very well done, very well done.
Yeah. And I have to say, Ahmad, the vein that you captured on echo is fantastic. I've never seen one as this one. It's like the textbook, so amazing. So well done. Good.
Yeah, we recommend this to watch for all our trainees. Maybe I will just present it at one of our grand rounds, if you don't mind.
Great. That's an honor. Yeah, please do.
Thanks a lot, then.
Cool. Any more questions? Okay, thanks, Ahmad. That's amazing. Thank you so much.
No, thank you very much from everybody. Thank you, and see you later then.
Bye-bye.
Bye, guys.